Hello, everybody. I'm Paul Komesaroff, and I would like to welcome you to our interdisciplinary workshop on voluntary assisted dying. Today's our second session, and it will be a focused discussion on participant experiences of voluntary assisted dying. I'd like to acknowledge the traditional custodians of the various lands on which we're all located, and to express my respect for the elders past and present. In today's discussion, we're going to have a number of brief presentations followed by an open discussion, and all the people here, both the panelists and the attendees, are very welcome to participate. Yesterday, we had our opening plenary, which we thought was very helpful and very successful. But we've given some thought to how we can make the sessions more interactive. It's really been one of our concerns here to really find a way to make Zoom meetings a real, kind of forum for conversation and exchange of ideas. Many of us who've battled with Zoom over the last 2.5 years have realised how difficult that is. So what we've decided to do today is to try and keep the introductory talks really quite short. In fact, I've described them as provocations rather than as full completed arguments. And I've asked the speakers to limit themselves to 5 minutes each. And after that, we will move to the broader discussion. We have a number of panelists, and we've decided that we won't necessarily go through all the panelists one by one to give everyone a chance to speak equally, but rather just to leave it up to them to chip in if and when they feel it's appropriate and helpful to do so. We would ask people to really think of how they can contribute to the conversation. It's not really a question and answer session. So, if you've got a comment to make, maybe address it to the group so that other people can join in the conversation. There is a chat line, and you're welcome to participate in that and to contribute your comments and maybe indicate that you'd like to make a point publicly, to ask a question or make a statement of one sort or another. Could you, unless there's a reason not to do so, make that available to everyone? Yesterday, there was a little bit of confusion about who was seeing what, because you can target the chat to smaller groups. So maybe if, as I say, unless there's a reason to do otherwise, if you make your comment public, then we'll all be able to see it, and it will be a much more inclusive and interactive conversation. The order of the talks today, we've got 5 brief talks, as I said. Camille La Brooy will go first, and I'll introduce her in just a minute, followed by Hayley Russell, Sadie Dunn, Michael Dooley, and then Alex Holmes in that order. And then, as I said, we'll move to the wider conversation. So without any further delay, I'd like to introduce Camille. Those who were here last night already know Camille. Camille is the project coordinator. She's a sociologist, social theorist by background, and Camille's been really the key person for coordinating, running and supervising the project. So Camille's job is to give us a bit of an overview of the data that we've collected so far. Camille, thank you.
Thanks, Paul. So hi, everyone. Thanks for joining us today. It's lovely to see so many familiar faces, or names rather, in the attendees list. As Paul mentioned, my name is Camille and I'm the Senior Study Coordinator and Research Fellow working on the project. And I'm just going to be talking very briefly about some of the findings from our project. As Paul has already gone through our research questions last night and our key aims, I won't be repeating them tonight. And I'll also not go into our research methods in great depth, but if you do have a question about them, please don't hesitate to ask in question time, and I can give you some more information about what we did for the study. So in terms of presenting the results, as you can imagine, of a project of this size, there are many, many findings, and I'm just going to go through a few of them. And I've chosen these ones as I hope they'll be interesting launching pads with which to generate discussion later. So to give you an overview, one of our findings was about clinician attitudes towards VAD. And in our sample, most participants were supportive. So 45 out of the 65 clinicians were in favour of VAD. 5 were neutral, 5 didn't clearly say one way or the other, and 10 were unsupportive. Among those 10, about half identified as conscientious objectors. Healthcare professionals also discussed their decision-making rationales, whether to support or participate in VAD. From people who supported VAD, people discussed the fact that they wanted to provide patient-centred care and were focused on fulfilling their patients' wishes. They saw VAD as filling a necessary gap. Many saw VAD as not very different to other end-of-life practices, life-ending practices. Many observed that pre-legal euthanasia happened anyway. Some empathised with their patients, saying that it's something that they would want if they were in their patients' shoes. They spoke about wanting to provide a good death, and many felt palliative care couldn't necessarily relieve all forms of suffering. From people who were more sceptical of VAD, they discussed the fact that VAD was contrary to the intent and purposes of medicine, and they spoke about the so-called slippery slope, which was something we touched on last night. And that's something I'm sure you're all familiar with, which could potentially render certain populations particularly vulnerable. And some felt that VAD was ostensibly the same thing as suicide, and that it was facilitating a suicide. So it was something that was morally wrong and against their personal, religious, cultural, or other ethical beliefs. And the findings from the longitudinal interviews, we did interviews, follow-up interviews with 22 clinicians afterwards, and they pointed to the fact that there was greater acceptance of VAD and that processes tended to be more workable. Divisions and sensitivities felt to be less apparent and impactful than originally feared. So a couple of those findings that I mentioned that I'd like us to focus on are that in our ensuing discussion are how traditional ideas of success and failure seem to be challenged in end-of-life care as a result of VAD, and also the idea that success and failure and what it meant was often contingent on one's position on VAD. For example, for proponents, process level factors such as eligibility, the ability to obtain prognosis, to be able to find appropriate coordinating, consulting doctors, speed of access, fewer barriers, fewer bureaucratic challenges, etc., were all determining factors of success. And conversely, for those who oppose VAD, they were more focused on processes of dying, such as the ability to make a patient comfortable, factors such as the quality and duration of life, and they were indicators of success. And at times, of course, these indicators came into conflict. For example, when patients were required to maintain capacity to consent to VAD, and clinicians felt that their patients experienced bad pain outcomes or died a bad death waiting for the VAD processes to be carried out. And another key finding is that the role of healthcare professionals and their identities seem to be changing. So interestingly, responses also varied according to partisan perspectives. So for those who supported VAD, there was a sense of fulfillment, personal fulfillment, about improving aspects of care such as medical communication, filling that important need I mentioned before, and ceding some power to the patient. And there was also the idea of clinician activism that was talked about. And so while some felt the need to be flag bearers, others shied away from that limelight and appeared to be not wanting to be seen as some ambassador of a particular movement. Whereas for opponents, that was often viewed as contrary to the role of the medical profession and a contravention of the Hippocratic Oath, and something that was fundamentally ethically problematic. And so these findings really raised some questions for me about how we assess quality when perspectives are inherently divided. In terms of the patient results, there were findings about the various challenges of accessing VAD, navigating the healthcare system and VAD processes simultaneously and having to be one's own advocate, and the challenges of going through all this while experiencing treatments at a precarious life stage. There were findings about VAD in the law. So some patients mentioned unknowingly that there were breaches in the law. For example, when asked about how they found out about VAD, they mentioned that their doctor or a nurse told them about it for the first time, or their GP might have printed them out some documents, for example. There were findings about the doctor-patient relationship, and it seemed that the doctor-patient relationship wasn't negatively impacted by a doctor's decision not to practice VAD. So patients mentioned that they might have spoken to their practicing doctor and found out that they weren't going to help them through the process, but this tended not to affect their opinion of their treating clinician. There were also some findings about mood, and perhaps Steph can talk about that later. And there was also no obvious correlations between religion and VAD, which we found quite interesting. So the key findings I'd like to talk through, perhaps in the discussion time if we have time, would be the idea of some findings around patient motivations. And there tended to be a lot of self-related motivations that were fear-based. So for example, fear of potential suffering, fear of losing autonomy, a fear of being able to maintain dignity, a fear that their end of life would not be congruent with the rest of their lives and that their identities and how they saw themselves. There was often fears about the fact that they were losing their life, or their life was diminishing in value, and that it wouldn't be what it once was. And there were also other related findings. So for example, family members would see them suffer, lose dignity, and that they wouldn't be remembered in the way they wanted to be remembered, that they'd be seen to be wasting away and without dignity. And they feared being a burden, and they feared their loved ones couldn't get on with their lives. So interestingly, physical suffering was rarely a primary motivation. And so I guess for me, this raises some questions about the role and perception of suffering in society and how it's conceptualised, how we think of the concept of personhood, identity, individualism, relationships with both self and other, and the valorisation of certain ways of being, like health, able-bodiedness, youth and wellness. And now I'll hand over to Hayley, who's going to be talking about some of our carer results. Hayley will be speaking as both a clinician and someone who has helped with some of the data analysis. But will be mainly, you can see some of the results on the screen here, but Hayley will be talking about bereavement. So I'll hand over to Paul, who might introduce Hayley in greater depth.
Thanks so much, Camille. Camille's really introduced Hayley, so there's not much more for me to say. Hayley, welcome. Everyone, Hayley is an experienced counsellor who has a background in counsel care and grief and loss work, but especially within a community palliative care context. Over to you, Hayley.
Thank you so much. And my slides aren't as nice and pretty as Camille's, but it might be helpful just to read through as I talk briefly over some of the themes. As Camille said, my focus coming into working with the team has been primarily on bereavement. So that's what I'll talk to today. So the themes that we began to notice as we were analysing the data specifically from families afterwards was a discussion around the family member, the person that they love, their personal values, and the way that people use this to make meaning after the person had died. So talking about things like they had a value around dignity, they had a value around pragmatism, and how they used this to create a narrative as the person was dying and afterwards. That really relates into some of the work that we do in grief and loss counselling around narrative therapy and meaning making. So made a lot of sense, but also that we really noticed, and this links into what Camille was talking about before, about fears, is that they were thinking about an alternative where someone would not have control or dignity, and that would create worry and fear for them and that person. So there was a real knowledge of what about the idea of for instance, a good death versus a bad death. I'll leave some of the clinical implications perhaps as an open discussion that we can have afterwards, and that many people who are attending may have thoughts on what this means for the care of family afterwards. But when we think about the next point here, so the expression of the continuing bond, again, thinking about things like legacy, there was many participants that we spoke about, family members who wanted to tell their loved one's story afterwards. So they talked about talking to their communities, to their friends, but also in lots of examples, talking to even the media, newspapers, doing interviews around their loved one's access to voluntary assisted dying, as part of, this is something that they would want. I want to destigmatize it. I want to make it more available for other people. And again, that this was helping them to continue that bond with that person that had died, and felt comforting for them in that time of bereavement. We also looked a little bit at the idea of anticipatory grief, which is what many people experience, especially when they have a family member who has a terminal illness, but a certain type of strangeness or surrealness or weirdness that they expressed around knowing precisely when voluntary assisted dying would happen and how and why, and conversely talking about the real benefits for themselves of that as well. I knew why, so I could have these really important conversations. There were things that my loved one really needed to say to me, lessons that they needed to pass on, that we were able to do because we knew of that as well. So there was sort of this two sides to anticipatory grief there. And again, you know, I think I want to leave the clinical implications discussion for afterwards, but that might tell us a little bit about what family members are looking for both during their care and afterwards in bereavement as well. I won't talk too much to VAD and unique aspects of burden of care because Camille's really mentioned it before, but there were certain situations where the most distressing thing in bereavement was what the family had been through during the process of applying for VAD, because they were in a rural or regional area and they had to get their family member to appointments. And that was the thing that was really distressing them even in bereavement afterwards. So that's something for us to think about as well. And then finally, I'll just say that their experiences of support during and after the VAD experience, many people talked to us about wanting some kind of VAD-specific bereavement support, that they perhaps attended a psychologist or looked for grief counselling, but felt that it wasn't specific enough, that person didn't know enough about voluntary assisted dying, and therefore it wasn't quite meeting their needs. So this is some of the things that have started to emerge, and same as Camille, would love to open that up to hear questions, comments when we have the opportunity.
Thanks so much, Hayley. And I just remind people to get their questions and comments ready for when we've finished the talks. Our third speaker is Sadie Dunn. Sadie's a palliative medicine physician at the Peter MacCallum Cancer Centre in the Royal Melbourne Hospital, with wide-ranging clinical expertise in providing palliative care to patients with advanced disease. So Sadie, thanks very much for joining us.
Thanks, Paul. And I'm just briefly going to talk a little bit, I guess, about my experience of caring for patients who do access VAD. So as you say, I'm a palliative medicine physician at Peter Mac in the Royal Melbourne, and we're really a busy service that has inpatient beds, consult service, outpatient clinics, community outreach, a telephone advisory service, a real wide range of palliative care services. And I guess I thought it was important in the first instance to really kind of lay out my position on VAD, and I guess I'm best described as deeply ambivalent. I'm pretty clear that VAD is not palliative care, and I don't provide VAD as a coordinating or consulting doctor, but I do look after lots of people who access it, and talking about VAD and exploring the concept and the complexities of it has been a really significant part of my practice for at least 2 years now. And I think it's also worth noting that in general, the palliative medicine community as a whole doesn't sound to me like it's well represented by the data that Camille has has presented, just I don't have figures, but just off the top of my head, I think it's important to say there's not that many palliative medicine physicians providing VAD in Victoria, and a notable few who are very deeply opposed to it. I suspect many sit in my camp in that deeply ambivalent sort of space. But the hospitals I work in are very supportive of the legislation, and so we're regularly caring for people who access VAD, as you say. And my first experience of looking after someone who accessed VAD was 2 days after the legislation came into effect. And I think the first person I looked after who took the medication would have been just a few weeks later. And if I'm honest with you, in hospital, it was a circus. Hospitals were grossly underprepared. It was enormously stressful, I think, for all the teams looking after those patients. But since then, the processes have been really streamlined, and I have to say the statewide navigator system has played a pretty important role in joining up that care. And their expertise at guiding patients through the process has been pretty vital. And I've looked after lots of people who've accessed that in some way or another with the help of the navigators. I think overall, my experience has really varied from broadly positive. So those patients who've come in, who've completed the formalities of VAD with plenty of time to spare, and who've decided to come into a palliative care unit to take the medication. And when this happens in a planned and measured way, when we can plan for nurses who feel comfortable with the situation to be allocated to the patient, who feel well supported by their managers, then it actually works pretty well. Personally, I find it sometimes a bit jarring to talk to a patient, maybe on a ward round, or talk to a patient who's effectively awake and alert and competent, and then hear that they've died a matter of minutes later, because it's so far from the usual run of events in palliative care. But I think these experiences, these positive experiences, have really convinced me that VAD should be treated like an elective and not emergency procedure when it comes into hospital. And that may mean that patients have to be a bit flexible in their timing when it comes to VAD to some degree. But I have also had quite a number of negative experiences. It's often the patients who pivot very suddenly from avoiding thinking about death at all costs, from I don't want to die, I don't want to die, I don't want to die, I only want to talk about treatment and hope, to I want to die now. And that's it, I want to die right now. And that's actually quite common. That they're often patients who have resisted referral to palliative care earlier on, and so we don't necessarily have the benefit of time to build a relationship with them. And I've come across a few patients who've really resented us for not being able to, or resented me personally actually, for not being able to provide them with death at a moment's notice. They really want the control, they hate being made to wait, and they hate the system for making them wait. And that's been a real challenge. Another challenge that I've really noticed is that VAD often seems to happen outside the system that we work in. So the assessments that happen, even if they occur in the hospitals we work in, they're not documented in the notes. The clinicians looking after patients don't necessarily know what point VAD is up to. And it's interesting how patients find that to be unusual. They find that off-putting when the clinicians looking after them don't know what's happening. And I do wonder if that can be a barrier to good care, that lack of integration of the two systems, because I don't think it engenders trust in the patients. But the most challenging situations, and actually sometimes distressing for me, just happening again for a patient I've been looking after for a while, just this week, is a patient who's in the process of losing capacity, but who really wants to pursue VAD, and they're in the assessment process. And these patients and families often refuse adequate symptom management. They refuse pain relief, they refuse sedation, even though they've got a terminal delirium, and we're in this tricky position of trying to balance their capacity for their assessment. And I have felt a number of times that possibly that person would have died quicker and more comfortably if we had been able to provide them with usual symptomatic management. But I mean, that is very patient-centered. If that's the most important thing to them, then as a team, we can focus on the VAD. In many ways, I've actually been surprised by the reaction of other health professionals as well. And it reminds me sometimes that I exist in a bit of a palliative care bubble where we have a sort of one opinion. But I remember providing a debriefing to the nurses on one of our palliative care units after the first patient took VAD. I was really surprised to hear how positive the experience had been for them, and especially surprised to hear how positive the experience had been for some of the nurses who were really deeply Catholic. And they even expressed that to me themselves, that they'd been really opposed to the principle of VAD, but they found caring for the patient to be rewarding and, in their words, beautiful. So in summary, I have to say, my practice has probably changed in the last 2 years. If patients bring up VAD with me, I explore it. I explore the thinking behind the request. And for many, a reassurance that we won't hold sedation and analgesia at the end of life is enough, and they don't want to pursue VAD. But for those who really do want to pursue it, I have to admit that I now will talk to them about looking into it and getting on with the assessment as early as possible so that they can follow that elective process rather than trying to make things work in an emergency. And at the end of the day, it's actually just the day someone dies. And I've looked after hundreds of people on the day they die, maybe more. And it's made me reflect on how lucky I am to be embedded in a really wonderful interdisciplinary team that's able to have the space to think about these difficult issues together. Thank you.
Thank you, Sadie. That was great. There are lots of issues for us to take up in the discussion that follows. Our next speaker is Michael. Now, you met Michael last night. Michael Dooley is the director of the Victorian statewide Voluntary Assisted Dying Pharmacy Service. So in that capacity, he's involved in all aspects of the service and has been really deeply involved right from the very beginning. So he's been able to see how it's evolved over this period of time. Thanks, Michael.
Yeah, thanks, Paul. And look, I'll give a little bit of insight into our experiences. From a personal level, I got invited to help turn the legislation into sort of the process, and was involved in very much around the medication associated aspects and the development and then the implementation. And and as part of that, I'm in charge of the service, but I also see patients, and I've seen lots of patients over the journey. With our services have seen many hundreds of patients now. I suppose the key bit initially was what could go wrong was the perspectives often. And so far with the many hundreds of patients that we've seen, we know the medications work. We know that anyone who has started to self-administer has taken the medication, and we've been successful in what it was designed to do. So that's been good. We also know that around about 75% of patients who get a permanent in Victoria will actually ask for the medication. And of those patients who we see, 75% of those that we see will take the medication, 25% won't. So you sort of have this 25% sort of figure that's one that I find is easy to remember. I think in regards to the experiences, and I think I'll probably just reflect a little bit on the experiences we've had. We go into people's, wherever they are, we get invited wherever they are, whether that be hospital, whether that be nursing home, whether that be their home. That's where we go and we see patients. And 50% of the patients we see are planning to take the medication ASAP. In other words, within 2 days. Initially, it was around about 75%. So when we walk into someone's house, 50% of those patients that we see are planning to take the medication that day or the next day. And many patients that we see will take the medication as we leave and will tell us that's what they're doing. And we'll often get a call from the family and all the coordinators and others that the patient has passed away before we've made it back to work. So that's the context that we're working in. What we do find, and what's been interesting over time, is that the families have been incredibly welcoming, and their carers and the hospitals and everywhere else. There's been a few instances where that hasn't been so welcoming, and that was probably earlier on. And there's been a real challenge in some of the palliative care services, in all honesty. I think we get to hear, and the patients want to share their story and their journey and why they're making the decision. And they will share that with us as the first sort of introduction that we have. So they share their vision, their plans, they share the why, they share the when, and they share the where. And often we'll work through that with them because that will be possibly taking it there and then, or maybe the next day. What we do see is as we arrive and as we go through what we do, the patients get more relaxed and get more comfort. And we see the opposite in the families and the loved ones. They get more anxious, and we see that physically in front of our eyes. The family getting anxious, the patient getting calmer, broadly. And that's because the family are at the realization that the end is here. And often the family is unaware that the patient is now planning to take the medication today or tomorrow. So that's something that's been a challenge for us. We often get asked, can we help them take the medications? Can we make it for them? Can we stay while they take it? And we've had to leave houses, and I've had to leave houses where the person is by themselves and they're taking it 30 minutes. They're taking it as soon as you walk out the door. And some of those have been challenges, but we also get feedback from the carers afterwards, and about 50% of people will write to us and write a narrative afterwards and tell us how it went, and that is incredibly overwhelmingly positive. The challenges and the hardest bits, I think, is the suffering of the patient that you see, and primarily the suffering of others, and we witness that. We witness their stories and they share their journeys with us, and we're in the house and we're sitting on the bed like other clinicians, and that is a challenge. We have to explain to them what's going to happen to them, and we're explaining that while everyone else is watching. The rest of the family is there. We have to get them for self-administered medication. They have to show us they can take it. So they actually do a dress rehearsal. We witness a dress rehearsal, and we witness their family watching them do a dress rehearsal. And that is one of, I think, probably the harder things that comes with the service. It's a real challenge to leave, and as I mentioned, sometimes it's the patients who are taking the medications in the future, it's a little bit easier. For those that are taking it today or tomorrow, it's often a lot harder. And I think one of the challenges personally as a practitioner, it's then you leave that environment and you go back to day to day. You hop in the car, you drive back to work, and you deal with the rest of the stuff. And it's I think that's a real challenge as a practitioner. But overall, our experiences with other practitioners has been wonderful, with the medical staff, nursing staff, coordinators when we visit places. There's been a small number of unpleasant interactions with some health professionals, but that has been in the tiny minority. And so it's been an issue, but it's been in the tiny minority, and we see many people who are supportive of what we do, and we work very closely with the medical staff, the coordinators, and FAD coordinators at sites and navigators. But I'm very happy at discussion time to take any questions about our experiences. Thanks.
Thank you very much, Michael. And I appreciate what a profound experience this must have been for you, for being involved right from the very beginning. Our final speaker is Alex Holmes. Again, you met Alex last night. Alex is a consultant psychiatrist who's head of the Consultant Liaison Psychiatry Unit at the Royal Melbourne Hospital. Thanks, Alex. You're muted, Alex.
Thanks, Paul. I'll just share my screen. Hopefully that's coming up. Perhaps I won't share my screen. It doesn't seem to be coming up. Thanks, Paul, for the invitation to present today. The topic of the discussion is really voluntary assisted dying and depression. And you've asked for something provocative. I think the very title itself is provocative, but I thought I'd add a little bit of sort of flesh to that to aid with the discussion. First of all, who am I? I am the consultation liaison psychiatrist at one of them at Royal Melbourne Hospital, and my role is to best of my ability, respond to the needs of the hospital, both the staff and the patients. And it was inevitable with the advent of the Act that there was going to be a role to play within the Royal Melbourne Hospital. And as requests were made to me and my service to provide psychiatric assessments for patients requesting VID, I decided I would make those assessments to the best of my ability. We know the details of the Act, or the capacity criteria under the Act are very typical of those for other areas of medical practice. Perhaps the only caveats we need to be aware of are that, given the seriousness of the decision, there is a principle whereby the more serious the outcome, the more rigorous the assessment. So I think we do apply that in our capacity assessments. Secondly, just to remind ourselves that people are assumed to have capacity, and that if we want to make a finding of them not having capacity, we need to have evidence that that's the case, and in a way demonstrate that evidence. Now, one of the most common reasons for questioning capacity, apart from organic cognitive impairment, is mood impairment. Now, mood is an affect which is sustained over time, and by its very nature defined as something that colors the way we view the world. So one can argue that any mood will affect the way we make our judgments. In this situation, however, the question is being raised is whether the presence of a low mood, to the degree that it may be considered either major depression or at least significant depressive symptoms, constitutes some inability to fulfill the criteria, in particular, mostly the ability to weigh up information as a part of the decision-making process. Now, this is not necessarily a black and white consideration, but I should say at this point that up until VAD legislation, it was generally considered by most psychiatrists that any wish to end life was abnormal. It's part of our kind of law. And this notion obviously is a challenge for us in VAD and for others. When making the assessment, therefore, we obviously make an assessment of capacity, but then try and place this request within the larger context, both the diagnostic context, but also the context of the formulation. And the formulation is that aspect of psychiatry, which is, well, we emphasize to a great degree. It's probably not unique just to psychiatric practice, but it's the alternative to a simple diagnostic approach, which is the attempt to ask the question, why does the patient present with this problem? In the case of VAD, why do they want to end their life at this time? And often what we come up with is a formulation or a explanatory hypothesis based on a range of factors, developmental, interpersonal, here and now. And it's useful to note, and we've heard this from Camille earlier today, that what we know about VAD is that, and increasingly from the literature as well as the most recent study, that the rationale given by patients doesn't necessarily focus on physical suffering, albeit the legislation seems to emphasize this as a sort of key component of the rationale for the legislation, and also needing to be present. The other rationales that people raise often have a strongly psychological, for want of a better word, component: fear, loss, a wish to maintain control, and self-determination. And often a combination of these are present in the narrative, which leads to the request. Now, these may occur in the context of people saying, I feel unhappy or even depressed or lack enjoyment in life. So the two are not mutually exclusive. And at the end of the day, we are forced to use this complex formulation, which is an explanatory hypothesis, as well as the criteria to answer the question, is there any grounds for actually preventing the process going ahead? In my experience, that threshold has actually been quite high. In fact, the patients who I've found to be most depressed who are requesting VAD often request VAD outside the context of the criteria. So they're saying, I want to die now. Can you please, can I access VAD? I don't have a terminal illness and I'm not going to die in the next 12 months. So it's almost selective. They're part of the evidence for their severe depression driving their wish to die is the fact that they're not even sort of aware of the full criteria operating in the context of a terminal illness. The last point I'd like to make about management, and one of the practicalities, is that in treating depression, you know, a course of treatment may take 1 month, 2 months, 3 months, and often this is greater than the life expectancy of the person concerned. So there is a danger that in pursuing a course of depression, one actually precludes the use of VAD, at least acceding to the patient's request, which represents a sort of ethical dilemma for all concerned. So in putting these sort of my experience together, a few of the questions which I've kind of identified, but don't necessarily limit to this, is at what degree of impaired mood represents an adequate evidence of impaired judgment whereby capacity is impaired to request VAD. Following on from Camille's question, I guess the notion of does fear or loss of control or identity or loss of dignity constitute adequate intolerable suffering, as seems to be implied by the Act? Are there any other methods we should be thinking about other than the traditional notion of capacity in determining eligibility for VAD? And again, as Camille's identified, what are the implications that the presence of VAD now has in our community of our attitudes towards suicide in general? Thanks, Paul.
Thank you very much, Alex. That was also very helpful. So thanks to the 5 speakers, and thank you for keeping to time. We're now going to go into discussion, but I think I'll ask for a couple of quick comments from 2 people on the panel that we haven't heard from previously. Stephanie Matthews, whom Camille mentioned, who can quickly introduce herself, and Jim Howe, who's a neurologist and a practitioner in this area, both of whom I think will present some other useful perspectives. So I'm just asking for some quick comments. And then I thought I would so I'm just signalling this so that you can get ready. Cameron McLaren's in the audience. I might ask Cam if he will make a quick comment after that. And then I'll ask Jenny Phillips' guidance, looking at the chat for who to go to next. So if you're happy to proceed in that way, Steph, over to you.
Thank you for that, Paul. So yeah, like Camille mentioned, I've been looking at the quantitative study analysis for mood and attitudes to VAD. So I'm actually a clinical psychologist with an interest in end-of-life care. So it's really interesting hearing Camille's data from the qualitative study as well, because it very much aligns with what we found in the quantitative data. So we looked at people that were wishing to proceed with that, and we actually found there was a significant relationship with anxiety. So this was regardless of whether they were eligible at this point or not. So it's kind of what you were saying as well, Alex, is they might not actually meet criteria at the point, but they're actually presenting saying, no, I'm feeling really anxious about this. At some point, I'd like to proceed with VAD. But then once people became eligible for VAD, there wasn't a significant relationship with anxiety. However, for those that were wanting to proceed with VAD that were eligible, and for those that actually were proceeding, we found there was a relationship with depression. So those people that were already proceeding or were eligible to proceed had higher rates of depression. Although interestingly, talking about this idea of a threshold as well, so we looked at a measure of depression and anxiety using the DASS, so the Depression, Anxiety and Stress Scale. And based on that measure, our sample actually had mild levels of depression and anxiety. So talking about a threshold, there's clearly a relationship there, but it wouldn't even meet criteria for a diagnosis. So it again comes to this idea of there might be symptoms, but what is that threshold? So again, really interesting in the context of both Camille and Alex's presentations tonight.
Okay, thanks, Steph. Jim, would you like to make a quick point from your particular perspective? I don't think the view of the neurological patient has really been presented here. So maybe just a quick comment in relation to what you've heard from your point of view.
Yes, thanks, Paul, for excuse me, for inviting me along to this meeting. How can I put this? My first acquaintance with the idea of VAD came long, long ago while I was working as a neurologist in the United Kingdom. And it was a curious phenomenon that patients with ALS, with motor neuron disease, would often bring up the subject of euthanasia and want to discuss it at the clinic. And this wasn't something that I saw from patients with Parkinson's disease or multiple sclerosis or other conditions like that. And then I came to live and work in Australia and found myself working at a specialist motor neuron disease clinic, the statewide Progressive Neurological Disease Service, and found myself involved with patients who wanted to withdraw from non-invasive ventilation. And I had done this once in the UK, where compared to Victoria, hardly anybody gets ventilated with motor neuron disease, although more recently. And it seemed to me that this wasn't actually much different from what people in Holland, what neurologists in Holland had told me about their euthanasia program. The patient told you that they wanted to come off VAD, they were off NIV. They told you that, and it was obvious they were dependent on the ventilator, and you spent a lot of time discussing with them, discussing with their family, and then putting them to sleep and taking away the ventilator. And then VAD came along, and I was involved in some of the planning for it and giving information about neurological diseases, and then found myself with patients who wanted VAD and who went through with it. And being a member of the VAD board, I wasn't involved in their care except to make a comment about their prognosis. But from what I've heard from other neurologists and so on, it doesn't seem to me, it's the feeling of it doesn't seem to be any different from how I felt about withdrawing non-invasive ventilation. And that's takes me to Sadie's point that it's an elective procedure. And that's something that the VAD board reports have tried to emphasize. This is an elective procedure. We talk to people about withdrawal of ventilation when we put them on it. That might be 2 years before they're ventilator dependent and might want to come off it. And it's a process of talking about it. And I think that's perhaps how it's going to go with VAD. People will talk about it earlier in the situation, and before they get to the 12 months or the 6 months, and then it will become a more obviously elective procedure, because certainly from the feedback we've seen at the VAD board, those people who are doing what you might call a rush job on it are the ones who get into strife and get into difficulties and unhappiness about the whole procedure. However, the other thing I would like to say is that, as Michael Dooley pointed out, the patients of mine who have gone down the VAD path have taken, all of those who did it have taken care to prepare in advance a feedback letter to send to me, and their families have almost all come back to visit us at the clinic after the procedure was over, even though none of us at the clinic were involved in the process, because the clinic happens to be situated in a Catholic hospital. So the people who I've experienced who've chosen VAD all seem very keen to, all have the reasons for wanting to do it, as Camille outlined, and are clearly motivated to thank the people who've helped them. Which I find really very touching.
Thank you very much, Jim. Now, I'm going to ask Cameron McLaren to make a comment. I'll ask you, Cameron, you've been involved as a health practitioner here, as one of the consultant physicians, and I'd be interested in your personal experience. That's the focus of today's session, of course. There are a lot of other issues for us to discuss. I'd like to talk about the assessment of suffering and the different concepts of suffering that are involved. There are the psychiatric issues relating to mood and suicide and so on. And the questions of assessment of capacity and the role of the changing levels of capacity, questions of bereavement and so on. All of these things have been raised in these very rich talks that we've heard. And as I indicated at the beginning, we really want to foster an interactive conversation. So I'll ask the panelists really just to make comments when they feel that they need to do so, without having necessarily being invited by me. And I'm inviting the members of the audience to indicate that that they might like to make a comment as well. Cameron, are you happy to talk? Go ahead, we can hear you. Now you're muted again.
He has a hardware problem.
Cameron, while you're drawing breath, I wonder.
Yeah, so we'll wait while we're waiting for you. We'll go.
I think that should be working now.
Okay, good on you. Go ahead.
Thank you, and thanks for the invitation, Paul. So I guess my reputation precedes me. So I'm one of the Victorian Community of Practice clinical moderators, and as Paul said, one of the early adopters of VAD assessment providers as a medical oncologist in Victoria, and due to the requirement to have one specialist in the area of disease and the majority of patients applying having a cancer diagnosis, the need for a medical oncologist to be involved was quite high early on. And I was willing to see patients who weren't my own in order to assist them with their applications. So that then snowballed into me seeing many cases. And to date, I've been involved in over 200 cases of application for VAD. I haven't kept track of exact numbers, but there is a spreadsheet running, and been present in support of the patient and their family on over, I think it's 50 to 60 occasions now, with many of those being intravenous administration. I think it's really pleasing to hear some of the themes that I talk about being emulated from some of the research that's come about. I think Michael's point about things being very rushed early on, with the 50% of people wanting to take the medication very early. It certainly didn't feel like this was an elective procedure for many of the times, because people, by the time they figured out that they wanted this, it was too late. We did a case series of 344 of community of practice patients that found the average time, or the median time, to deliver medication from first request was 36 days. And for people who would, by definition, with a diagnosis or a prognosis of less than 6 months, that's quite significant. And for many of those, they had to withdraw during the application process due to death. So I don't know that it's, this is an elective procedure, and I do know that the board does say that this is not an emergency procedure, but I'm not sure that that's up to us, and it's kind of dictated by the circumstances of the application many of the times. So it does feel like an emergency application at some point. I can see my internet connection is unstable, so I apologize if I'm coming through choppy. Sadie, I think there was a couple of points that you made that really resonated with me, particularly in some of those cases that present that you do feel as though that their death could have been obtained or granted quicker and more comfortably through standard palliation. I certainly have seen that, and that is regrettable when that happens. And I think it comes down a lot of the times to actually being very frank from an assessor point of view, and actually saying to patients, look, if that's what you want, this isn't the way to get it. We should just treat you in a standard fashion and make you comfortable, and things will happen quicker than the time taken. So I think there's a real art to the assessment provision, and the quality of our prognostication and communication skills in that area really need to be developed. And that's led to, not only the community of practice talking about this, but if I can put in a plug for our VADANS group, which is VAD Australia, New Zealand, which is similar to the Canadian CAMAP group, the Canadian MAID practitioners, and ACA-MAID, the American Clinicians Academy of Medical Assistance in Dying. So it's meant to be a cross-jurisdictional support group for providers of VAD across the jurisdictions to try and improve these sorts of aspects of VAD care that we perhaps didn't expect to encounter. I think those were all the points that I felt. I think the point that Alex made about firstly, I think you know, when you talk about some of these patients and the journeys they've had and the point in the journey that they're up to, it would be unusual for them not to express some depressive symptoms, and whether or not that constitutes clinical depression and affectations on clinical decision making is a separate question. But you know, it's almost as if they did not express some elements of depression, you'd actually say, well, you're not really connected with where you're at in your disease process, I don't think. When you talk about suffering, Paul, and the nature of suffering and how we assess that, often it is just explaining that this law is open to, these are the eligibility criteria, and the condition must be causing suffering, and tell me about your suffering. And often I say that without saying, you know, you must jump through this hoop. Just when I'm talking to them, I'll ask them, and sometimes the suffering is just palpable and you actually don't need to address it directly. But in that instance, we say, you know, what do you feel about your, you know, tell me about your suffering, and that's much more important. And I think I learned that trick through one of the community of practice members, who said that he's stopped asking patients about their pain and started asking them about their suffering through the descriptions of the suffering that has been experienced by many of these patients. So I think our involvement has also affected how we practice in our non-VAD jobs as well, in certain ways too.
Okay, thank you, Cameron, for those very valuable comments. And look, I think I should also mention that people have referred to the care navigators and the important role that they're playing. And I know that we've got at least a couple online at the moment who may or may not want to contribute directly, but I think it's important to acknowledge the critical role that they're playing, which I think is universally acclaimed. Jenny, who should we go to next?
Paul, I was hoping to channel some of the chat. There's been a little bit of discussion, and Jacqueline Elliott put some comments in the chat. Again, just picking up this notion of suffering a little more, which came up yesterday, and Jacqueline highlighted the suffering and the psychological sequelae of psychological illness or psychiatric illness, and that constitutes suffering, and how that plays out. But also I think the notion of threshold is perhaps interesting. Alex raised that in relation to depression. Is there something in relation to suffering? And I guess the last bit is our response to suffering as a world, given, as we've heard, and internationally also is the case, that these are existential social issues, very real and very significant, and, you know, fear of these things and our response to those. So I'd be interested in comments on that from the panel or the audience.
Yeah, Jacqueline, do you want, since your name was mentioned there, do you want to add to some of the things you've put in the chat? You'd have to unmute if you did.
Jacqueline and I had a discussion before, Jacqueline, and she was happy for us to make that, but I see you here.
Hi, I have actually unmuted. I find I'm not particularly good at putting my thoughts into words when I'm talking to people. I actually can be more succinct in writing it down, which is why I've written those points through. So I had a number of issues that I was curious about. In part, I'm thinking of the family's experience and curious about what that's going to look like, particularly if there's a perception that VAD promotes a less bad death by truncating suffering, if that might in some way lead to perceptions of grief that's not as severe, or as, no, you know, they should be happy that they didn't go through that suffering in some way. I'm wondering about that, because I know people are always already quite insensitive in the things that they say to people when someone's died. And just so wondering about that.
I'm happy to speak briefly to that, Jacqueline. Thank you. I saw that questionnaire, and I think the word we often use is disenfranchised.
That's it.
Parts of your grief can be, disenfranchised, because, well, this is something that you work towards with your loved one, you helped them, and I think it takes. This is why, you know, I'm excited to be involved in this research and to disseminate it, because it takes a nuance from a health professional afterwards to acknowledge both the parts which felt, I don't want this at all. I've been with my family member as we've fought against cancer, and now we're coming to this different ending. So to acknowledge those parts, as well as the parts which respected their wishes, which were glad to see a sense of peace or calm, or something about a ritual, the place that they were when they died. So I think that you know, this kind of research can then help health professionals to normalise and validate a whole lot of experiences that can come after voluntary assisted dying.
Yeah, I guess my concern there was absolutely making sure that the clinicians are prepared for that. But thinking this is bigger than just that. This is a community issue that the community has to recognise, to shy away from those constructions that VAD is in some way less painful than any other form of death.
Yeah, agreed. And look, yeah, absolutely, working with families every day in grief, that's a whole huge societal educational question about just sitting with the really tough parts of things that happen for everyone. But would agree that, yeah, some education for the community in general would also be really helpful around this. Yeah.
Thank you for that. Jenny, Philip, would you like to comment on your thoughts about suffering? You've just put something in the chat, and I know Sadie had some thoughts about that too. Some people have raised the point about how some of the stated reasons for people to seek voluntary assisted dying, such as loss of control or fear of loss of control, strictly speaking, might not fall within the criteria of the existence of intolerable suffering. But also there's been concerns raised about how ticking the boxes in that area may not be the same as actually providing the sort of care that may otherwise be available. Are they fair comments, Jenny?
I think so, Paul. I think that there's a little bit of discussion going on in the chat about the how we respond to suffering, which is deeply uncomfortable and deeply challenging for us all to be in the presence of someone suffering, and how we, Cameron said, you know, actually asking the question and asking it in a very open way is one of those important steps. I think that we don't ask, we don't really want to know, we're very uncomfortable when we recognise it, and perhaps avoidance can mean that it can get worse, at least go unattended or go unwitnessed, which is perhaps almost as bad. I'm wondering, maybe Sadie and then perhaps Naomi Katz, who's in the chat, might like to comment on that as well.
So Sadie and then Naomi.
Thanks, Jenny. I agree. I think it was really fantastic from a palliative care perspective to hear Cameron as an oncologist say that he'd really kind of learned from this process to ask that question, tell me about your suffering. I guess that might be one of the first things we learn in palliative care when we're thinking about communication, about death and dying at all. And I'm totally aware that we have access to that training, and that's a major part of what we do. And it would be lovely to see that throughout health in general, not just in oncology, not just in relation to voluntary assisted dying, but when we're thinking about patients who are entering aged care, when we're thinking about patients in all kinds of situations, that question, tell me about your suffering, opens up a whole different world of compassionate care for patients and their families that often looks very different from the medical model. And I think often responds to their suffering in a much better way, or often allows response to their suffering in a much better way, and probably in a more rational way when we're thinking about health economics and things like that too.
Thanks. Naomi, are you happy to talk?
Thanks, Jen and Paul. Can you hear me okay?
Yes.
So there's a few things I think come to mind, and I think the piece that Sadie just mentioned and Jacqueline's put in the group, in the chat as well, I think there's a real risk of us medicalising things that are not necessarily medical or best served by being labelled as a medical issue, and a lot of the social suffering that we see, and I think we've been worried about as triggers for people potentially asking or thinking about voluntary assisted dying, and us not meeting the needs of, you know, mental health and aged care and so much broader that's partly medical but not just medical. But I think the piece around suffering and how comfortable or equipped or willing we are to sit in that space is a huge issue. We recently did a retrospective notes review with Jen and Michelle Gold and a couple of our team at the Alfred, and one of the things that was really interesting was pulling out triggers for people either making a desire to die statement or asking for a voluntary assisted dying review, and what was going on for that patient, but also how clinicians responded. And even though psychological distress or existential distress was the most frequent sort of trigger or issue identified, responding to physical symptoms was much more commonly identified as a response by clinicians. That was both PAL care and non-PAL care specialists, so treating teams as well. So I think it really is a wider issue for us to think about. So thank you.
Okay. Thank you. And Jenny, I'll ask who we should go to next. But I just also raise one of our objectives in this project more broadly is to establish a framework for assessing and reviewing the voluntary assisted dying experience with a view to improving or refining the system, maybe even to amending the legislation, but also in relation to community and health professional education as well. Camille mentioned the issue of the criteria of success and how they can actually distort or at least affect or redirect practice. So if anyone would like to make any comments about that, you'll be welcome to do so too. Jenny?
I was hoping to perhaps we might ask Brian Kelly, who's one of the attendees, who's to perhaps talk a little more about the discussion of the impact on the clinicians or on the care teams, and perhaps couching that discussion, if you have any comments, Brian, on how we may think about this in our evaluation. That would be helpful.
Thanks, Brian. You have to unmute now.
Can you hear me now?
Yes, we can. Thank you.
Yes, look, I think there's been a number of really important issues raised, and I think this issue around how we respond to suffering that drives a request for voluntary assisted dying is a really fundamental one. And I just wanted to add, I guess when we're talking about fears and concerns, when we look at the crisis that we're facing in aged care and mental health care, there's an enormous paradox here that we're not addressing the impact that has on people, and other things other steps we need to be taking to address those problems. And also, of course, the national crisis around suicide prevention and the deeply ambivalent messages that we're potentially sending when we see the extension of any discussion about assisted dying to people whose primary problem is psychiatric illness or struggling with other challenges or crises in their life. In regards to the impact on clinicians, there was some work that myself and colleagues did a little while ago, just looking at the published literature on this, and it does identify, I guess, a varied set of responses, some of which was reflected in what Camille had presented. Some clinicians in some respects feeling that was personally fulfilling, but also reports, and this is from the international literature and mostly qualitative studies, that identified some deeply mixed feelings, particularly in the longer term. The feeling that it altered them fundamentally personally, because it, not necessarily on religious grounds, but fundamentally about what they felt their role as a doctor was. This was mostly about doctors and their impact on them. Some quite traumatised by their involvement and the difficulty of discussing it with colleagues and others. So maybe some of the other strategies that others have talked about mitigate that in this instance. But I think it's very important that we, as we explore this, provide the opportunity to hear the mixed feelings that clinicians might have, not only in the short term, but in the longer term. And also, I guess, acknowledging that we're dealing with a select group of clinicians who have, in this instance, elected to be involved. And that may be different to studies internationally, where there's been a broader group of clinicians engaged in some of the research that's been done. But I think it's a very important issue for us to think about, the role of the clinician, the impact that facilitating the death of a patient has when it is contrary to everything else that we might feel is part of our value as a clinician. And then what, particularly as we are aware, the longer term, short and longer term challenges to the well-being of health professionals. I mean, it's been evident through COVID, just the load that they carry, and the focus that's been on clinician well-being. So it's a perspective I think that's really important to keep a very open mind about.
Okay, that's a great point. Yeah, I was just going to ask you, Camille, if you wanted to chip in. Go ahead.
Sure. I think that, as you pointed out, Brian, that the fact that in other jurisdictions there might be a more encompassing, all-encompassing approach to VAD, because it's a self-selecting group of people. From our quantitative data anyway, the mood scores like anxiety, depression, etc., of clinicians participating in VAD seem to be better than baseline. So I don't know if that's an indication. And then people tend to talk about there, I mean, obviously are challenges like emotional challenges. They talk about the costs, financial, as well as personal and opportunity costs of doing other types of things. But overall, I think the reason why people continue to participate is because they derive some sort of personal benefit from participating in VAD. And I think that that's why perhaps, and Cameron can perhaps tell me otherwise, they continue to participate and in VAD. So that's perhaps why the results point the way they do.
Okay, thank you. I thought I might ask Charlie Cork if he'd like to make a comment. I know, Charlie, you've been thinking about these questions quite a lot. If you'd like to make a comment, you'd be welcome to do so.
Can you hear me?
Yep. Please
yes,
go ahead.
I think I would endorse Cameron's comments that there are conscientious participants in this. So there's conscientious objectors, but equally there are conscientious participants. It's not well remunerated. It's not well, it takes up a lot of time. It's a big commitment to clinicians, and they do it because they're conscientious participants. So I think that needs to be taken on board as well. And a lot of the feedback that we get is that clinicians feel that it's one of the most, among the most satisfying things that they do, as opposed to being destructive of their well-being.
Yeah. And Michael, Dooley, the way you expressed yourself made me think this was as being quite a big experience for you personally too. You used the word overwhelming at one point. It must have been a difficult journey, and you know this is not something that you've actually been doing as part of, you're a pharmacist rather than an oncologist or palliative care physician, so a lot of this must have been new.
Yeah, look, my background, I used to work at Peter MacCallum, and so my background was oncology, so I worked in day treatment facilities for many years and had many conversations. Used to work in the pain and palliative care unit at Peter Mac. So had conversations with patients about, you know, symptoms and those circumstances. I think the thing that we see or we get the most feedback is from the family, from the patient at the time, who feels that they have they're supported in their decision and that they have control of their decision, whether they're making that decision now or in weeks to come. And the feedback from the family and the carers that we received post a patient taking the medication. And the most common word that we get is peaceful. And that is what, so that is the main reward we get, is the comments of the many hundreds of patients who've given us feedback, is around that they had a peaceful and planned death, and that's I suppose the most rewarding component. So we get to see, and I say we leave a little bit of ourselves behind, and we take a little bit of the patient with us after these visits, especially those ones that are in the position of taking the medication very soon. But there is I think from a practitioner perspective, significant reward associated with being involved in a very difficult time for them and their family. So it is a rewarding experience, albeit has its complexity and burden that we no doubt all clinicians endure and take on that responsibility.
Thank you. And I just remind the panel members, just jump in if you've got something to say.
Well, I'll just echo what Michael's been saying about what people say about ventilation withdrawal. The word peaceful is the one that comes up, came up. I'm retired now. That came up all the time with you know, and I felt exactly the same way about it when I was involved in it.
Could I perhaps raise the issue of the relatives within a family who may be opposed to it, and what we're seeing in grief counselling beyond the death of the patient, whether they're what experiences perhaps Sadie or others have had in that area.
Sadie, do you want to comment?
I think, Ian, the question was about grief counselling, and I guess that's something that, as a palliative care physician, it's not the bit of the team that I
think that's Hayley's job.
Yeah.
But what about the resistance from the family question?
In terms of resistance from the family to VAD itself, is that the question? I think the vast majority of people I have, of patients who I have talked to about VAD, with one notable exception actually, their families have been broadly supportive, even if that's not the choice they would make. I think there's something about the duty to fulfill someone's dying wish that's important here. The notable exception was an extraordinarily distressing situation for a wife who had been a very active anti-suicide campaigner all her life. And her partner or husband pursuing VAD was really difficult for her. But I don't think I've come across any other situation where the family has not been supportive, even if that's not what they would have chosen.
Hayley, do you want to comment on those difficult situations?
Yes, I would say there isn't the data within our cohort. You know, all of our families pretty much had the experience of supporting that person. There's a bit of data overseas to say if there was moral ambivalence for those family members, that they did struggle in bereavement because there was an ethical issue for them there, and they had those ongoing questions afterwards. I think I sometimes apply what I would apply to all families where there's been a terminal illness, which is this: if there is complexity, so ambivalence in the relationship anyway, and other stresses happening, then that can come through. So there are some examples I'm thinking of in my mind from my practice where there wasn't an opportunity to actually have that goodbye and to have that that peacefulness necessarily. And so that's been something that's brought into grief counselling and discussed afterwards, and has caused a level of distress. So there's a question of, is that to do with voluntary assisted dying, or would that have been present no matter the way in which the person has died? Yeah.
Thank you. Jenny, who should we go to next?
You caught me making some notes. Peter's got his hand up. Thanks, Peter.
Thanks very much, Jen. Question for Michael, if I might, and it relates to, I think you said there's 25% of patients who are prescribed the VAD medication don't go ahead and utilise it. And I'm just wondering whether you've got any reflections on why you think that's the case, and or whether or not there's any sort of international literature which may give some level of understanding as to why it's fairly large proportion. So quite interested in some of the reasoning around that, if you have that those insights. Thank you.
Yeah, look, I think there's a group of patients that I think just want to have control, and their control is that if they decide that they want to be able to take it, they want to have it available if they therefore want to take it, but it doesn't mean they're going to. And we have those conversations with quite a lot of patients who will say, look, I'm not sure whether I want to take it, but I want to know that I've got it available if I do, and that gives me a lot of comfort. And so there's a cohort of patients that fall into that, and I think whether they just continue to just go through their natural course and decide not to take it would be a significant proportion of that. Then there'll be those patients that for whatever reason lose the capacity to be able to take it, and when the time comes, they're unable to, either because of just their function or their cognition. And so I think there would be a cohort of patients that would like to take it but are unable to take it because of their physical decline or cognitive decline. And in Victoria, you then have to sort of start again to get practitioner administered, and it just may be too difficult to do that. So there's probably the two groups: those patients who would like to take it but are unable to take it because they've deteriorated further. And then there's that cohort that wanted it and wanted to be able to have it available if they needed to, and have decided not to take it. And they've got two groups. And we have patients who sometimes contact us and go, look, change my mind, can you come and pick it up?
Yes, thanks, Michael. We've just got a few minutes left, and maybe we should have a little bit more of a conversation on this question of capacity and mood and so on. Ian Kerridge, perhaps you would like to comment on the question of the assessment of capacity, or the kind of fluctuating capacity of patients in this context, and what impact it might have on the momentous decisions that we're asking them to make here.
Thanks, Paul. I don't know if I've got any expertise in capacity or capacity assessment. Perhaps the only thing is that maybe it's reflecting something that Camille presented from the data, and then and that Cameron and Charlie talked about as well a little bit, which was the motivations for putting requests and proceeding with assistance in dying. Camille mentioned that it sounded like it was all framed in terms of fear, which perhaps lends itself towards the mood and so forth. And I'd wondered if that's actually true, or if it's really people stating intentions in terms of positive things, meaning making, maintenance of memory, maintenance of identity, maintenance of agency, and so forth, which is a very different thing to fear of loss of agency or fear of loss of dignity and so forth, and whether that would. So I was just a little bit confused by how the data was presented, and whether that's reflective of the kinds of motivations that people have.
Thanks, Ian. Camille, do you want to respond?
I think that I guess it's a bit of both, probably, and it's a big question when we're looking at the philosophy of identity and identity projects, etc. How one's identity can be constructed or perceived, perhaps. But yeah, often it was expressed in terms of a fear, and I think the mood scores really correlated with that. The fact that they had higher than baseline than the rest of the population anxiety and depression scores. So perhaps it was just the cohort.
Can I
could I ask Cameron and Charlie just to reflect on that as to whether in their experience that these were positive acts or whether they were avoiding things?
Okay, great. Jenny, though, you wanted to jump in there.
Oh, I was just going to say that, as you know, Ian, often if people have pieces or goals or things that they wish to achieve even very late in the last phase of life, achieving those can be an extraordinarily sort of positive thing. And I wonder if perhaps achieving access to VAD might be sort of conceptualized in some of the same ways.
Thank you. Would anyone, Cameron McLaren, can we bring you back again? You've got a good point here.
So just, I think the point that I just put in the chat, sorry, I got distracted by typing that, but I think I've had many conversations with patients that, you know, one of my first questions is, why does the concept of VAD, you know, appeal to you? And many people reference a death experience that they have had or been a part of, and that they don't want to burden their family or their children or their friends with the same experience that they had. And often it's a case of saying, well, what kind of support did you receive when you were looking after your parents, you know, 30 years ago? And then talk to them about the supports that are available today. They still carry with them, again, misconstrued ideas of what palliative care provides. And I have been able to introduce many patients through to palliative care through their applications for VAD, and even if it's just by saying, look, I understand this is what you want and that's perfectly fine and you're eligible and we'll process the application, but I can't have you having these symptoms whilst we're waiting for this to go through, and I would really like to introduce you to this team. It's not going to delay your application, it's not going to get in the road. But so I think that's been a way that VAD has actually been positive in terms of facilitating access to palliative care for many patients who would have otherwise flat out refused it.
Okay.
I do think we're changing that perspective on death and providing alternate experiences, and whether they're through VAD or non-VAD, or you know, or palliative care with the access to VAD that's never taken. You know, I think we're improving things like palliation of end-of-life fear and those sorts of things through the combined end-of-life care of both palliative care and VAD.
Thank you very much. We're pretty well out of time. If any of the panelists would like to make a quick final closing comment, now's your opportunity to do so. Otherwise, I will bring the conversation to a close. We've covered a lot of material, but there are a lot of issues that we didn't get to, but that's not a bad thing, because this will be a continuing conversation. And as Cameron Stewart said yesterday, there is a need to continue the conversation in all directions, not just because it remains difficult, but because the cultural circumstances and the political circumstances may change, and we need to prepare for that as well. So that's the end of tonight's workshop. Tomorrow, which is same time, same place, we'll focus on the administrative and legal issues, and that will be led in conjunction with Cameron Stewart. So until then, I wish you a very good evening, and thank you very much for your contributions tonight. Thank you.
Thanks,
Bye-bye,
Paul. Thanks, everyone.
Thanks. Bye, everybody.